Well, I think as James points out, there's been a lot of ethical discourse during the COVID-19 era, but perhaps not as much of a focus on the outpatient world where much of healthcare is delivered. So I thought I would try in the 10 minutes I've allotted to focus on that, just a brief introduction to some of the issues that we've encountered in dermatology, and I think will have some relevance to you all as well. So I'll jump right in. No relevant financial relationships to disclose. I think we can all appreciate some of the real challenges that COVID has put forth, particularly in the context of shortages. And I think that's really going to be the focus of the brief talk this morning. Stories out of Europe about ventilator allocation and critical care physicians having to make decisions about essentially who lives and who dies in a way that was really unprecedented. That also, of course, affected us here as alarm bells were ringing about critical supply shortages in the United States, both with ventilators and also personal protective equipment, leading to proposed policies that were really unimaginable, say in February 2020, for example, this article depicting a potential universal do not resuscitate for COVID patients out of concern for supply shortages as well. But I think the question really becomes, how do these issues of shortage affect us in the outpatient world? And I think sometimes the connections are not apparent, but I just bring forth a couple of these questions that were really posed to me from colleagues both at Emory and across the country that I think reflect the way in which critical shortages during COVID have affected the outpatient world. So for example, a colleague who sees a lot of connective tissue disease patients and has many patients on Plaquenil, posing questions about whether he or she should use another agent. There was a period where Plaquenil was in short supply, and questions about whether it was more appropriate for COVID patients. How should we handle issues of drug shortages during a pandemic? Also questions about redeployment. I think that something we have not faced as much in Atlanta, but certainly in other urban centers, those of us with day jobs that don't involve critical care, under what circumstances should we consider voluntarily being redeployed, or perhaps in a mandatory way being redeployed to the front lines, quote unquote, ICU or emergency department. I think maybe more relevant to us and maybe a little less intriguing on its face, what do we do with all these patients we've canceled? In dermatology, we probably had 2 or 3 months worth of canceled in-person appointments. We attempted to shift as many as we could to the virtual space, but it just didn't work for many of our patients, as I'm sure is true for you as well. And then as we came back and capacity was not 100%, particularly for in-person appointments, what do we do with these patients? Who should be seen first and why? So I'll use these as a frame for how we might think about ethics in the outpatient world during COVID-19. So in the few minutes we have, I'm going to touch on a couple of things. One, I'm going to try to explain why the pandemic has been challenging for healthcare providers, particularly from an ethical perspective. It certainly has challenged us medically. It's challenged us financially. But why is it a challenge for us ethically? And I'll talk about why it's, in part, that has to do with having to wear sort of 2 hats, the hat of the clinician and the hat of the public health official at once. I'll briefly touch upon resource allocation schemes that are well described and how those resource allocation schemes have been particularly assigned during COVID-19 and some ethics recommendations having to do with them. I'll touch on a couple of applications to outpatient medicine. This is constantly evolving. If we have time for questions, great. If not, no worries. So I'll start with a multiple choice question. Ethics and multiple choice don't get along that well, but just to get everybody thinking, the primary focus of clinical ethics during a pandemic state is which of the following? So just think to yourself here. I think probably apparent to most of us, it is the public, right? This is in distinction with how we might think about clinical ethics during a non-pandemic state or non-crisis state, right? So this has to do with a really important ethical tension that we experience during public health emergencies. So remember, like clinical ethics in the normal state, I refer to the quote normal state because maybe there is never a truly normal state. But I think if we think back to February 2020, what were the kinds of ways we were thinking about healthcare? And then now, how has that shifted? So in the quote normal state, there are things that are very familiar to us. The focus of our care is on the individual first and foremost, and things which hold up individual liberty and autonomy. things that we engage in regularly with patients, like informed consent and shared decision-making, the ways which we're measured, which is how well our individual patients are doing. Shift now to the crisis state, and the focus becomes the public. And you can see these are kind of in distinction with what our focus is in the normal state. You know, our values focus more on aggregate populations, things like fairness or justice or utility, things like triaging and rationing. And the outcome for us is the public's well-being, often at the expense of the individual. So I think part of what makes the COVID era and eras like it challenging for healthcare providers is that we're forced to sort of shift between what is good for the individual and what is good for the public. They're often in conflict. And I think an example of this is some of the really staggering data coming out of China showing mental health effects on healthcare providers caring for COVID patients, partly because they're having to play two roles at once. Let's shift focus to resource allocation schemes. So although it may seem confusing, there really are a very limited number of ways in which we can think about how to prioritize people for getting resources when they're in very short supply, right? So these are just classically described. The idea of treating people equally. This is a kind of familiar method to us, primarily in the form of first come, first served or queuing, right? So this is really the way, at least in dermatology, I'm sure for you all as well, appointments are made. So if somebody calls first, they're going to get the appointment ahead of someone who calls second. Not so commonly used in healthcare is random allocation. And I'll talk about a way in which we tried to incorporate this into our COVID response in dermatology. It's something that's utilized in other realms of society, but just kind of a foreign actor in healthcare. But people have made a case that this is probably more fair than a first come, first serve model, simply because of, you know, the privilege of being able to come in early and wait and be ready for an appointment or a resource from a patient. Another allocation scheme is prioritizing worst off. This is the sort of, you know, ED model, if you will. Someone who comes in who is sicker will get fast tracked as opposed to someone who comes in who is less sick. This is an appealing model for those of us in the caring profession. However, I think it poses problems because it doesn't pay as close attention to post-intervention prognosis. So you can imagine someone who is very bad off but does not have a significant chance of recovery. Being allocated resources could be problematic in the long term. Another appealing strategy is what's called benefit maximization. So this is really looking at what interventions does the most good for the most people. This is a kind of cornerstone of public health ethics and has a lot of appeal. It does have some shortcomings. So for example, vulnerable populations are at great risk when we really focus on maximizing benefits. And we've seen some of that play out during the COVID era. And then finally, promoting social usefulness. This is sort of related to benefit maximization. This is the ethical rationale for, you know, assigning priority to healthcare providers, you know, government officials. You can imagine, though, as we focus on social usefulness, there's a lot of susceptibility to corruption here. This is part of the reason why, you know, athletes and other celebrities are getting tested and others cannot. So all of these are, you know, have certain contexts in which they're useful. All of these have certain contexts in which they are not, and typical responses involve some number of these. Now, I just make a note here, ability to pay is not included in prioritization schemes during periods of severe shortage. That's debatable, but it's not typically included by ethicists. Hope that doesn't make your business manager nervous. All right, so how about during a pandemic like COVID, which guiding principle of the allocation schemes that we have should be the principle which guides most policy? Just thinking for a moment here. So we're in a pandemic state, which should be the guiding principle for most policymaking? Well, the answer here is benefit maximization, right? It doesn't always guide policy, but according to ethicists, this should be the principal guidance for policymaking during COVID. So a group of ethicists, you may be familiar with this paper. It was a very influential paper early on in the pandemic in March, published in New England Journal, where ethicists primarily from University of Pennsylvania got together and put forth recommendations for resource allocation, particularly in the context of COVID. And number one, first and foremost, was benefit maximization. And what they mean by this is essentially years of life. So likelihood of survival and number of live years saved. This is really like the primary metric for COVID policy. So it's really purely years of life. as a corollary to that, frontline healthcare providers should get priority first. This was also expanded in many healthcare systems to include vital healthcare worker infrastructure. This is part of Emory's policy for resource allocation to not just include providers, but other people critical to infrastructure. This was an interesting inclusion for patients with similar prognoses. Consider a random selection model as opposed to a first come, first serve model. Very importantly, because evidence was evolving all the time, there was a guideline recommendation that things should evolve as evidence evolves. So as data about treatment and other interventions evolves, the guidelines should change with it. And we'll see how that is particularly relevant to the story of hydroxychloroquine. An importance placed on research participation. So those participating in clinical trials for COVID should get rewarded. And then really most importantly, and I would say especially important to us in outpatient medicine, that there really is no morally relevant difference between those who have COVID and those who do not, right, when it comes to resource allocation. I think we've seen a lot of neglect of non-COVID disease, and where I think we're dealing with the implications of that now. But I think the ethicists really on the front end said, these are not different simply based on the fact that one patient has COVID and another one doesn't. So these are the recommendations put forth by ethicists. You can see how some of these fit well, maybe into outpatient medicine and some less so. So just to think about a couple of applications here, I can't help but harken back to a time when there was a lot of attention being paid to Plaquenil, as of course measured by number of tweets. In one day in April, there were over 100,000 tweets referencing hydroxychloroquine in the treatment of COVID-19. So a lot of attention being paid here. And many of us who use these drugs started to sound alarm bells. I mean, we saw publications in the rheumatology literature and then we in dermatology as well saying, we have many patients on this drug. We're having a tough time getting it. There was short supply and calls for reallocation of hydroxychloroquine away from patients who've been on it chronically and toward patients with COVID. And we begin to raise questions about whether that's really appropriate. So thinking about hydroxychloroquine from the perspective of the COVID principles we talked about earlier, first and foremost, benefit maximization. I think here we see Plaquenil and other drugs like it. The priority should be allocation to those whose survival would benefit most. Remember, like the quantification of benefit maximization in the pandemic is number of years of life saved, right? So here we make a case that maybe patients on this drug chronically for other indications should be taken off, right? And this was a case that was being made at the time. Importantly, though, remember those without COVID and those with COVID are considered morally equivalent as long as they are of equivalent severity. So those who are on the drug for potentially life-saving indications, severe systemic lupus, for example, had a reasonable case to stay on drug. Of course, very important, as evidence evolved about hydroxychloroquine, policy evolved with it. So I'll just raise this question. I'm sure you all are familiar. Randomized controlled trial data have shown which of the following about hydroxychloroquine in the treatment of COVID-19. I think as we know now, it essentially does nothing other than promote adverse effects. So this has really changed the game, a critical clinical trial out of Brazil, and then revocation of the emergency use authorization for hydroxychloroquine for COVID really changed the game and made the drug much more available for those of us who use it. Move on now to the idea of redeployment. So this was a somewhat infamous podcast interview with an Italian critical care physician saying that he had dermatologists being redeployed to the ICU who were crying every day, which I can understand, but really a legitimate question that came up in many urban centers in the United States. This was not only affecting dermatologists, but orthopedists, certainly ambulatory primary care as well, and legitimate questions being raised about whether this is an appropriate practice. I mean, it seems sort of intuitive to say, well, you should go to the place of greatest need, but what are the boundaries around redeployment that we should be thinking about from an ethical perspective? So again, redeployment kind of viewed through the lens of the COVID principles. First, of course, benefit maximization, but I also say, in the spirit of utilitarianism, benefit maximization and harm minimization, right? So it's reasonable to say that dermatologists and ambulatory, internal medicine providers should be reasonably redeployed if it saves the most lives. Remember, that's the driving principle here. However, I would argue that there's a limit to that. obligation, primarily in the form of training. So if you're asking someone to do something they're not recently trained to do, you potentially can do a lot of harm. I mean, thinking of myself having to intubate a patient with COVID likely is more hazardous than helpful. I think the other thing as we get more into the chronic crisis state, which I would say we're in now, this obligation must be time limited. I think it poses an existential threat to other services offered in the healthcare system that are vital for the chronic health of the healthcare system. And so, I think that is another boundary around redeployment that we would see. Also, of course, it doesn't necessarily mean providers, particularly those that may be high risk for COVID, and this discussion has come up in our department with some of our older providers, doesn't necessarily mean they need to be seeing COVID patients. They could potentially be doing something else that is considered frontline from a healthcare system's perspective. So I think redeployment is a reasonable case to be made for that from an ethical perspective, but it should be bounded both by the nature of the activities and by time. And then finally, in-person appointment allocation. This actually was a huge problem for us. We were kind of facing reopening and didn't have a good framework for thinking about how patients should get appointments. We had all of these canceled appointments, and then we had the regular scheduled appointments, and we had to negotiate that. So we put together a work group where we engaged in a modified Delphi, which is essentially a consensus building exercise, where I put forth some principles and we voted over them and sent out to the whole department and to a few patients as well, and came up with 5 guiding principles for how we should allocate our in-person appointment allocation during the sort of slow open phase or other phases that would lead to a shortage of appointments. 3 of them were benefits oriented. Remember, that's the driving force behind ethics policy during the pandemic. But 2 of them were justice oriented. I think we've seen a lot of injustices during the COVID era, probably because of a focus on benefit orientation. And we felt as though these need to be represented, particularly in the outpatient world, where we're seeing a lot of inequity at baseline and exacerbated by COVID. So what did we come up with? For the benefit maximization principles, we put a priority on healthcare providers. This was something that's somewhat intuitive, but even those with relatively mild disease, we really put them to the front of the line. So we had, for example, a provider who came in with, who called in with an inflamed cyst that was preventing masking. Again, not a acutely serious problem, but was interfering with his ability to carry out work, and therefore he got fast tracked for an appointment. We also prioritized diagnostic procedures, thinking that this would allow for better triaging. In our world, that's skin biopsy or tissue culture, but it could mean other things as well. A more kind of philosophical guiding principle was really just thinking about those who would benefit most from an in-person appointment, as opposed to those who are less well, who have poor long-term prognoses, or those who are less sick in general. The example we think of here is someone with hidradenitis who needed an abscess drained, who would have certainly ended up in the ED otherwise, got priority in our clinic. The justice-oriented principles, we talked about random allocation. We had a long list of patients with low-risk basal cell that had been biopsied over several months, and we just had not treated them yet. We had to decide how to allocate appointments to them. We essentially just randomly assigned them as opposed to queuing. And then finally, and I think we can all appreciate this one, those patients who just simply cannot carry out a telehealth appointment for a number of reasons, usually technological in nature, were also offered an appointment in person and prioritized. So just to review, we talked about why public health emergencies are challenging for us ethically, primarily because we are forced to wear the hat of the public health provider as well as the individual provider. Talked about the limited number of resource allocation schemes that are offered specific recommendations during COVID-19, and then a couple of ways in which these have been applied to outpatient medicine. So with that, thank you again for the invitation. I'm happy to entertain any questions if we have time. Otherwise, happy Monday to everybody.
This is Jim O'Keefe. I think in the interest of time, we'll hand it back over to Ted Johnson, but that was, I think, and that I speak for everybody saying that was really an excellent talk. And like you said, efficiency in our huddle, you really did that in a compact amount of space. So thank you so much.
Thank you again.
Hey, thanks, Dr. Stoff. We really appreciate that. There was one question in the chat box. I know some folks will have to sign off, but if you have a second just to tackle that one question, and also on Yammer, I put your recent publication in the box so that folks could reference that.
Yeah, I think I see here from Nate Spell. Hey, Nate. Speak to the duty to care for sick while incurring personal risk. I think this is a major issue. And I think it is not straightforward. So I don't know that we can delve into it in great detail, but I think that is part of my argument about redeployment here. I think there are limitations in the obligations we must incur on people because healthcare providers are such a critical resource. So I think anything that puts healthcare providers at risk should be thought of very carefully. And I think it's reasonable to withhold certain kinds of care or prohibit certain providers from participating in high-risk care because healthcare providers are such a critical resource. Remember that healthcare provider prioritization is also one of the major COVID principles. So I think it is totally appropriate to limit healthcare provider involvement in very high-risk activities if you're able to do so. But a longer conversation.
Dr. Stoff, thanks so much. And Dr. O'Keefe, really appreciate all of your moderation of these sessions. And just a reminder that this is all available on our Emory Department of Medicine YouTube channel under Primary Care Updates. And so in case you've missed one of these sessions or have a colleague who wanted to hear this but couldn't be here, let them know about it. Hey, let's have a great day. Thanks so much, everybody.